Thank you. So my topic today is lipoprotein apheresis. During the next half an hour, I wish to discuss what are the various types of lipoproteins, what is the principle behind the lipoprotein apheresis, the genes that are implicated in familial hypercholesterolemia, for which the lipoprotein apheresis is predominantly carried out. What are the various methods available for lipoprotein apheresis? What are the indications, guidelines, and are there any pitfalls and challenges in doing lipoprotein apheresis? These are the things we will try to overview over the next half hour. So before I come to the topic proper, I thought we will start off with the case history of how we became interested in this topic. This is a case of a 16-year-old female with deranged lipid profile in the form of hypercholesterolemia. She also had xanthomas on the eyelids. I have not shown the face here. And also on the left cubital fossa, as you can see here. These are due to cholesterol deposits. The echocardiogram showed mild valvular and supravalvular aortic narrowing, signs that she was developing cardiac complications. And genetic studies showed a LDLR gene mutation. Her parents gave a history of consanguineous marriage. The younger sibling of the patient was, however, normal. This was diagnosed as a case of homozygous familial hypercholesterolemia, and the cardiologist wanted to try lipoprotein apheresis for this patient. That was the time we came into the picture. So before I come to the procedure proper, a word about familial hypercholesterolemia. Familial hypercholesterolemia affects an estimated 1 in 200 to 1 in 250 people in most countries around the world and is thought to be the most common inherited condition affecting the heart and the blood vessels. It's an autosomal dominant disorder. Fortunately, the homozygous variant, wherein the defective gene is inherited from both parents, is rare as 1 in million, but some cardiologists believe it could be more common. It is just not looked for. The problem in the familial hypercholesterolemia is that it leads to premature atherosclerotic narrowing of the blood vessels, leading to cardiovascular disease, either peripheral or central. Particularly patients with homozygous disease are prone to coronary artery disease, myocardial infarction, and sudden death in the second decade of life. We have currently 2 patients with us, out of which one of them has lost his sibling because of absence of this procedure, absence of proper treatment. So the medical management for this condition is by use of drugs like atorvastatin, cholestyramine, cholesterol absorption inhibitors, and so on. All these were tried, and this patient did not respond to drugs. Hence, LDL apheresis was considered. The American Society for Apheresis, I'll come to that in a minute later on, also recommends LDL apheresis for the management of homozygous familial hypercholesterolemia. So what we used, the method that we used was, of course, plasmapheresis. But unlike in conventional plasmapheresis, where the plasma is removed and replaced with healthy plasma, what we did was cascade filtration or plasma filtration using this cascade. We used the Fresenius cell separator, which many of you are familiar with for this procedure, because literature showed that a lot of people were using this one. So the filter this model that we use was EvaFlux model 5A20. I'm mentioning this in case somebody wants to attempt this procedure at your center. So what this does is that here, of course, it can separate the cells and the plasma. This is also called cascade filtration, double layer filtration, double membrane filtration, that's because there is one membrane which filters the cells and the plasma. The second membrane filters the plasma further. Whereas since we are equipped with, we are not using a dialysis machine, but we are using a apheresis machine. Plasma was separated and went through this membrane. So what this one does, this plasma removes the high molecular lipids into the waste, but permits the low molecular weights like albumin and HDL to go through this membrane. So you have two layers. That's why it's also called double membrane filtration or cascade filtration. So it's very similar to plasmapheresis, except that for the fact that plasma is filtered, the cholesterols which we don't want are removed, and rest of it is returned back into the to the patient. So procedure-wise, the patient parameters were as follows. The patient's weight was 50 kg, height was 165 centimeter. The weight total blood volume at the rate of 70 ml per kg we estimated at 3.5 liters. The estimated plasma volume based on hematocrit was 2.1 liters. We primed the filter with 1 liter normal saline as recommended by the manufacturers. And for any apheresis procedure, you need an access vein and a return vein. The anticubital veins were difficult to access. So we had to use right femoral vein as the access vein, and we used the left anticubital vein as the return vein. The procedure on the whole took about 137 minutes. We processed 1.5 times the plasma volume, 1.5 times 2.1 liter, which came to roughly 3.2 liters. The flow rate was 40 to 50 ml per minute. The extracorporeal volume during the procedure was 340 ml, 160 ml in the plasma kit, 140 ml in filter, and 40 ml in the tubings. So this 340 ml is much less than 10% of 3.5 liters. The recommended is that the extracorporeal volume should not exceed 15% in any apheresis procedure. So, I don't think calcium infusion is required in this all these patients. However, since we were not sure how long the procedure would last, we decided that we will follow the same thing what we do for peripheral blood stem cell collections. So we infused IV calcium, each one vial in 100 ml of normal saline, and infused over 1 hour. The waste plasma that was generated was 500 ml. Therefore, we chose not to give any replacement fluids. We were able to process 3.2 liters of plasma and achieve the desired result. So these were the results. The total cholesterol, you will be surprised, which was 416 pre-procedure, came down to 124, a 71% reduction. Imagine how many months of treatment would be required to bring down a cholesterol from 416 to 124. The lipoprotein A, which was 283, came down to 68 within a matter of 2 hours, a 76% reduction. The triglycerides, not much change as you can see. That was because the triglycerides were not elevated as such. The HDL cholesterol again came down by only 25%. We don't want the HDL cholesterol to be lost. It came down from 28 to 21, but some amount of loss is inevitable. Then the C-reactive proteins also came down negligibly. The LDL, another important thing that we wanted to test was from 365, it came down to 92, so 75% reduction. So if you look at ApoA1, the reduction was very less, 21. If you look at ApoB group of proteins, which represents the non-HDL group of proteins, that came down from 2.37 to 0.695, a 71% reduction. So this is what we want to do when we are doing lipoprotein apheresis. We want the ApoB proteins quantity to come down, but not the ApoA protein. Fibrinogen was 296 pre-procedure, but for some technical reasons, we could not do it post-procedure. Then the platelet count dropped from 154 to 95. We just did this to know what would be the effect on platelet count. So this was the first procedure. Then this procedure, so as you can see, the LDL cholesterol came down significantly from a base of about between around 400 to it came down to around 70, between 50 and 100. Then we repeated the procedure 3 weeks later. We wanted to do it 2 weeks later, but we could not for various reasons. The patient came at this time. So as you can see, the mean LDL cholesterol had come down from around 400 to 300 by the second procedure. I think there's something wrong here a little bit. So this was the same case, 18-year-old female. Is just to show you that if we continue this procedure, the mean levels will keep coming down. Only 1 or 2 procedures will not be enough. So this is another case of homozygous familial hypercholesterolemia. Even in this patient, we achieved a reduction of 77% of total cholesterol, a 91% reduction in lipoprotein A. Then we achieved 83.5% reduction in LDL cholesterol. So as you can see, overall ApoB proteins came down by 82%. So definitely these two cases are enough to demonstrate that this procedure, lipoprotein apheresis by cascade filtration, is a very effective way of reducing the ApoB group of proteins or the non-HDL group of proteins. So the effect of lipoprotein apheresis on plasma lipids is that it reduces total cholesterol, it reduces LDL cholesterol, lipoprotein A all significantly. And if triglycerides are elevated, to reduce this also significantly. But HDL cholesterol, no doubt, is lost because this procedure is not very selective. It is semi-selective, but not to the extent of other cholesterols. So we now come to the principles of lipoprotein apheresis, why it is carried out. So by definition, the lipoprotein apheresis refers to the selective removal of lipoprotein particles from the blood with the return of remaining components. Therefore, here you don't have to give back plasma, hopefully, in most cases. Then if you look at types of lipoprotein apheresis, you can remove only LDL cholesterol, or you can remove LDL cholesterol along with lipoprotein apheresis. In fact, there are, I believe, filters exclusively for lipoprotein A, or normally what we do is a combined LDL and lipoprotein apheresis as was done in our case. So lipoproteins are basically of two groups, apoprotein A, which all the HDL group of proteins come under ApoA, and the non-HDL proteins like the LDL, the VLDL, the intermittent intermittent density lipoprotein, lipoprotein A, all of them come under ApoB. So when we are doing lipoprotein apheresis, we want a reduction in the ApoB proteins, particularly the ones which are elevated. So so I'll come to that later. Okay. Sorry, the slide is not in order. I'll come to that later on. So the genes implicated in familial hypercholesterolemia, the condition that was there in our patient was LDL receptor gene in our case. This patient had defective LDL receptors from both the parents. Therefore, it was called homozygous disease. But majority of cases, it is this LDL receptor gene that is defective. It leads to reduced clearance of LDL from circulation. Another gene that has been implicated is the apolipoprotein B receptor gene in 5% of cases. This leads to impaired binding of LDL particle with the LDL receptors on various cells in the body. Then you have a third gene, the PCSK9 gene, involved with LDL metabolism. So now, the LDL gene provides instructions for making low-density lipoprotein receptor. These receptors bind to the low-density lipoproteins, which you know are the primary carriers of cholesterol in blood. The LDL receptors present on the outer surface of most types of cells, and they transport the LDL into from the circulation into the cell. Within the cell, the cholesterol is released. And there it could be metabolized, it could be stored. So various things can happen to the cholesterol inside the cell, or it can be utilized in various metabolic pathways. Then you have the ApoB gene, which makes two versions of apolipoprotein B. The ApoB48 forms chylomicron. The Apo100 forms the building blocks of LDL, VLDL, and IDL. Chylomicrons help to carry lipid and cholesterol from intestine into the circulation, whereas these proteins transport fats and cholesterol in the bloodstream. So the effect of Apo48 is on the intestine, on chylomicrons. Apo100 is the effect is on LDL, VLDL, and IDL, which help in transport of fat and cholesterol in the bloodstream as opposed to the intestine. Then you have the PCSK9 gene, which controls PCSK proteins, which in turn controls the number of LDL receptors that are displayed on the surface of the cells. So LDL receptors, as you know, are particularly abundant in the liver, the organ that is responsible for removing the excess of cholesterol from our body. So coming to the methods of lipoprotein apheresis, therapeutic, what we commonly know is you can do a normal therapeutic plasma exchange and remove the plasma, but this you will not be able to achieve the desired result in one sitting. Probably you will need 3 or 4 sittings. The second method was what I have described so far, cascade filtration, also called as double membrane or differential filtration. This is used for removing ApoB atherogenic lipoproteins from plasma. When the first step, we use centrifugal plasma. Therefore, this term is called plasma filtration as opposed to using the dialysis machine. So, but this, however, is again a semi-selective method. Some amount of other proteins also get removed along with the LDL and VLDL and other things. So there are other more selective methods like antibodies, sheep and antibodies for apoprotein B immunoadsorption. This is another more selective method. Then the third method that has been described, fourth method rather, is heparin-induced LDL precipitation. And a fifth one called dextrosulfate LDL adsorption. All these three methods, immunoadsorption methods, precipitation, and adsorption methods, are better than cascade filtration. However, they're also more expensive than cascade filtration. Our Indian patients find it very difficult to afford cascade filtration, so we don't look at these things, especially given the results that we are seeing here. So to just give you an overview of the methods, in plasmapheresis, it is quick, well tolerated, eliminates various pathological substances, but requires multiple procedures. It is not selective. It comes with the danger of infection, bleeding, and risks of plasma or albumin. Cascade filtration, which I have described, is semi-selective because along with ApoB, some amount of HDL albumin also get removed. It comes with the risk of infection and lower effectiveness. Whereas immunoadsorption methods and then dextran sulfate, LDL precipitation, heparin-induced precipitation, all these are more selective, effective, and believed, but also expensive. Therefore, we used cascade filtration and not the other methods. So a little more about the method that we did. This is a filter-based therapeutic procedure that removes pathogenic substances, in our case, the lipoproteins, from separated plasma based on their size, which is mainly determined by molecular weight and three-dimensional configuration of the antibodies, immune complexes, or lipoproteins, and uses plasma filters with different pore sizes. So, as a standard procedure, lipoprotein apheresis is carried out using peripheral veins in the arms, mostly in 80% of patients. I think Germans have great experience in this. 15 to 20% of patients may need AV fistula. Our patients were particularly difficult. Now we are in the process of creating a AV fistula for these patients. Blood flow, you can take it anywhere between 50 to 100, 60 to 80 is suggested. You can process 1.5 to 1 times blood volume, or 1 to 1.8 times the plasma volume can be removed in one sitting. The duration of treatment normally takes 1.5 to 3 hours. This treatment may be needed weekly initially when it is very high, fortnightly mostly, and some patients very rarely, in 5%, twice weekly or even 3 times in 2 weeks. So like this, various frequencies that has to be determined depending on the patient. It's usually determined by the cardiologist. So what are the indications for lipoprotein apheresis in familial hypercholesterolemia? The homozygous or heterozygous familial hypercholesterolemia, diagnosis of this along with the LDL cholesterol level more than 300 is definitely an indication. Heterozygous familial hypercholesterolemia along with high cardiovascular disease risk and a LDL cholesterol even lower than this, 200 milligram, is an indication. Heterozygous disease along with cardiovascular disease or diabetes. In the presence of diabetes, you accept even a lower level like 160 milligram per deciliter, or even if the cholesterol is normal, progressive cardiovascular disease and with a lipoprotein A concentration more than 60 milligram per deciliter is an indication for familial hypercholesterolemia. That was as per one of the guidelines. I quoted the paper there. Then there are US FDA approved indications. Familial hypercholesterolemia homozygous, it says 500, whereas here it says heterozygous 300. I couldn't really understand why they have given this one. Whereas familial hypercholesterolemia with LDL more than 160 milligram in the presence of cardiac disease like coronary heart disease, and US FDA says patients must be on diet and maximally tolerated drug therapy for 6 months prior to initiating lipoprotein apheresis. Whereas there are other papers who recommend lipoprotein apheresis as the first line of treatment. Then Germans probably have more experience with this than anybody else in the world, from what I could make out and what I have learned from my cardiology friends. So it is used for primary prevention when in case of FH with LDL cholesterol more than 160 milligram per deciliter, and when the patient has cardiovascular events, disease and cardiovascular events have occurred in the close relatives. Like I said, in our case, one of our child's brother had died of cardiovascular disease secondary to familial hypercholesterolemia. That is why the parents were keen to save at least the second child. Secondary prevention, patients with progressive cardiovascular events and the LDL concentration in the range of 120 to more than 120 milligram per deciliter. Then even in the presence of normal cholesterol, lipoprotein A concentration greater than 60 milligram is an indication for lipoprotein apheresis. So the levels may vary, but by and large, it is accepted worldwide that lipoprotein apheresis is a very good treatment for familial hypercholesterolemia, or for that matter, reducing cholesterol levels, whatever be the cause. So what are the advantages of cascade filtration that we did? It's highly effective in reducing the non-HDL proteins, although it did remove some HDL proteins. The reduction was achieved, 60 to 75% reduction was achieved in just 2 hours. However, as I already mentioned, this is a semi-selective method, but it is one of the most widely used methods. Cascade filtration, unlike the regular therapeutic plasma exchange, needs lesser number of procedures. I'm sure we wouldn't be able to do it in one procedure had we done conventional therapeutic plasma exchange. So this is another slide to show you the reduction in cardiovascular events. This was shared by Dr. Iyengar, our cardiology friend. As you can see, 2 years before the procedure, there were 258 cardiac events documented in patients. 1 year prior to the procedure, that means they were having a longer duration of the disease, 417. But following 1 year after initiating lipoprotein apheresis, this fell down from 417 cardiovascular event to 105. It is 77% reduction, and further fell to 47 over the period of 2 years. So it is well settled that lipoprotein apheresis is beneficial and life-saving, but needs to be continued lifelong for optimum benefit. Normally, it is done once in 2 weeks. So what are the pitfalls and challenges? Pitfalls, some of them I have mentioned, the loss of albumin, loss of fibrinogen, and loss of HDL. Along with this, the more challenging part comes with the cost, as in everything else in our country. The cascade filter costs something like 40,000, and along with it, you need the therapeutic plasma exchange kits, and you need a HD catheter, insertion of which also costs money. So all these things make the procedure pretty expensive. The frequency of the procedure has to be done once in 2 weeks. It is not once in your lifetime. And there is a rebound increase in LDL in 8 to 13 days. That is why it is offered every 2 weeks. You cannot do it once and forget it. And then comes the problem of long-term venous access. If it is just once or twice to reduce the cholesterol levels, the triglycerides level, probably you can do with peripheral veins. Otherwise, you may need AV fistula, just like in dialysis patients. But many countries, even today, who are very well experienced, continue to do it using peripheral veins for life. Adverse effects, like any other apheresis procedure, hypocalcemia, and these patients are more prone to cardiac events because they have already, their hearts are compromised because of the atherosclerotic deposits. So it's good to do it using a cardiac monitor. You need definitely equipment, which I mentioned, basically a good cell separator and skilled workforce. I think there are other apheresis equipments also on which this can be done, but we did it on this machine. So other pleiotropic effects of lipoprotein apheresis include a decrease in C-reactive protein and other inflammatory markers. Could also cause decrease in fibrinogen and other coagulation factors when you go on doing it repeatedly. Therefore, you might need to monitor fibrinogen if repeated procedures are done. Then decrease in plasminogen and fibrinolytic proteins is another possibility. decreased complement levels, decrease in plasma and blood viscosity, and decrease in PCSK9 levels. The PCSK9 protein also get removed. However, it is believed that these proteins return to normal levels, and they are not probably clinically significant, though their levels come down a little bit immediately after the procedure. So there are various treatment guidelines. As I said, some of them recommend LDL apheresis as the first line of treatment in patients with homozygous disease and after drug failure in heterozygous disease. So if you look at the American Society for Apheresis guidelines, the American Society for Apheresis guidelines says that familial hypercholesterolemia for removing LDL, there is grade 1A evidence. In homozygotes, again, even in heterozygotes, there is grade 1A evidence. Whereas for therapeutic plasma exchange, that's also beneficial. There it is grade 1C evidence. Then if you want to remove lipoprotein selectively and not the cholesterol, and another variant which patients may suffer from, then there also we have grade 1B evidence. Even for peripheral vascular disease caused by LDL, there is grade 1B evidence. For students who might not know what is 1A and 1B, grade 1A means there is strong recommendation, high quality evidence supported by multiple RCTs. Grade 1B means strong recommendation, but moderate quality evidence, maybe RCTs have some limitations. So like this, their grading is based on the levels of evidence that we have. So you have got good evidence, grade 1A evidence in case of familial hypercholesterolemia and grade 1B evidence in lipoprotein hyperlipoproteinemia to carry out lipoprotein apheresis. So there are other applications of cascade filtration. In addition, apart from LDL apheresis, you can also do HLA antibody reduction. Prior to bone marrow transplantation, we have done one case of this, and we have had two cases of hypertriglyceridemia, where the triglyceride levels were in the order of 7,000 or 8,000. We were able to bring it down below 1,000 within one procedure in one patient, and it came down to 4,000 in the other patient after the first procedure, and below 1,000 it took at least two procedures. I have just missed one slide which I wanted to show you somewhere, so okay, doesn't matter. So the removal of the filtration depends on two things: the molecular weight of the compounds. Those which have, for example, the LDL, VLDL, IDL, or the intermediate density lipoproteins, all are heavier molecules. That is why they get filtered. Whereas HDL passes through the membrane and is returned to the patient along with albumin. So another factor other than the molecular weight is called the sieving coefficient. This refers to the solute concentration in the filtrate divided by solute concentration in the plasma. The sieving coefficient indicates the potential of different solutes to pass across a particular membrane. It is high for albumin. If it is high, it passes across the membrane, gets filtered, and is returned to the patient's body. If it is low, as in case of LDL, VLDL, then it does not get filtered but goes into the waste. This is how LDL is selectively removed and the HDL and albumin retained to the patients. So in conclusion, LDL apheresis using cascade filters is a semi-selective, highly effective method for reducing non-HDL proteins. It's a life-saving option in homozygous familial hypercholesterolemia, which is refractory to medical line of management. But there are authors who also recommend it as a first line of treatment. Studies show that major cardiovascular events were reduced by as much as 97% in the first year following lipid apheresis. High cost is the impediment for a country like ours. So probably we need to develop indigenous filters if this has to be offered to a large number of patients on a large scale. My experience with this is also very limited. I'm sure it is new to all of us. We don't do this in great numbers. But I'll be happy to acknowledge Dr. Aingar, our cardiologist, whom you can see here. I learned a lot of things from him. My associate, Dr. Ambuja, and Abdul Basir, who are all responsible, who played an important part in doing these procedures. So thank you very much.